Thanks, Stuart. Good morning. All right, what I'm going to try to do is, over the next 20 minutes, is to talk a little bit about establishing a high-performance research team and take you through that journey from the early part of my career in a very large research team, which is the National Consortium for the Women's Health Initiative. But I want to start you back to thinking about this from an Ohio State perspective. So it's been almost 150 years since the government established the Morrill Act, which really was the foundation for the development of the Ohio State University, because this is where, in fact, the land-grant institutions were originally funded. And as you know, the primary role for land-grant institutions initially was to actually create an opportunity for higher education to allow us to create the next generation of teachers and nurses and doctors and scientists that would actually improve the life of the citizens of Ohio and, in fact, the life of the citizens of the world. But over the last 150 years, the role of the land-grant institutions, and in fact, the role of the Ohio State University has also changed. So rather than simply being a disseminator of knowledge, we've actually become a creator of knowledge. And with that creation, we've translated that in ways that now has a global impact in areas. And so we have great strengths in basic science research at the bench. We have great strengths in clinical research at the bedside and great strengths of population research. But really where the challenge is how do we tie all those together? How do we take our greatest discoveries forward so that we actually, from a biomedical perspective, improve human health? And I think, as many of you know, if you've heard me talk about, this has really been an incredible challenge because it requires communication and collaboration and working together across all areas of that translation, from the bedside, from the bench to the bedside, to the bedside, to the community, to the public policies, and then listening to the communities, our stakeholders, who actually can help to frame those scientific questions together. And you know this process has been incredibly inefficient, that it takes on average more than 17 years to go from that basic science discovery to actually something that ultimately will change. And in fact, of all those discoveries that all of you are making on a daily or weekly or monthly basis, the majority, more than 99% of them will fail to translate. So how do we really develop the right group of individuals working together to actually make translation success? And I'd suggest to you it's because translational science is not individual science, it's actually team-based science. That we have to work together across these big areas of what we call the valleys of death, that between the bench and the bedside, and that between the bedside and actually implementation, in order to be successful. And so that the translational scientific teams of today actually require a tremendous number of individuals bringing multiple different perspectives together. So as you think about establishing your research teams, you really need to think broadly about what your end game is. Where are you trying to do this? Is it simply to focus deeply on a specific scientific question that you as an individual can answer, where you don't need other than your research assistants, postdocs, and others in your laboratory? Or do you really want to be part of this larger translational science group in order to move things forward, where your team's going to involve a tremendous number of individuals to move things forward? And of course, as investigators, as we all know, we're harmless together when we're alone, but get a bunch of them together with a research grant and watch out. So I'm going to give you a case study to kind of think about this from both a micro perspective, from the Ohio State perspective, and then that bigger national consortium perspective, and decided to reflect back to something that I certainly never thought when I was an early assistant professor would actually translate across my entire career, a study that's gone on for the past 25 plus years. And this is the Women's Health Initiative. So how many of you have heard of the WHI? Good. All right. So WHI is the largest. It involves more than 161,808 postmenopausal women, the longest, more than 25 years now in duration. and one of the most ethnically diverse and most expensive studies that the National Institutes of Health has ever undertaken. And it really was to address a whole host of scientific questions that related to the prevention and early diagnosis of diseases that were either uniquely or disproportionately affected women. Because up until that time, so you have to remember this started in the late 1980s for conception and in the early 1990s for actually the development, that in fact women were in general excluded from most clinical research studies because of concerns regarding reproductive or hormonal changes. And so the majority of research was actually done in men. And so we had a relative dearth of understanding of what happened to women as they aged. And the primary outcomes that were focused on this included breast and colorectal cancers, osteoporosis and osteoporotic fractures, coronary heart disease and stroke, dementia and frailty with an advancing older age group. And then there was the development of a very large biorepository linked to very detailed phenotypes and environmental exposures to help to begin to look at predictive models for the development of this disease. So to be able to do this, and this included 3 randomized clinical trials, one looking at the effectiveness of hormone replacement therapy or hormone therapy in postmenopausal women, a second at the supplementation of calcium plus vitamin D on osteoporotic fractures and colorectal cancer risk, and the third focusing on low-fat dietary modification. Required a huge research team, as you can imagine, to recruit 161,000 women over a 3-year span of time. So for the national consortium, we really needed to bring together clinicians who had discipline-specific expertise because we wanted to make sure that we really were considering the risks and benefits of these therapies and what were some of the areas, what were the major clinical diseases that we really wanted to be able to look at for predictive modeling. We needed nutritional experts in order to develop actually the intervention for low-fat dietary modification, which was one of our primary trials. We needed epidemiologists because, in fact, we had a very large study that had 3 randomized clinical trials as well as this large observational study. And then biostatisticians, you can imagine the complexity of the biomedical informatics and getting the relational databases together for this. The NIH funded this, and so we had multiple NIH program officers across 5 different institutes that supported this. We had industry partners that actually provided the supplements as well as the hormone therapy. There was a large engaged community group of advocates because they in fact helped to drive the development of this study. And we needed to bring in kind of early stage T1 investigators, those individuals with expertise on genomics, a burgeoning field of proteomics and metabolomics, really for developing out brand new biomarkers. Well, think about bringing that back now to a local team. So for developing a local team, when I wrote this, not only did we need a PI, which was me, but we needed co-investigators who, again, brought in that discipline expertise. So I needed cardiovascular scientists to be able to actually look at the EKGs that we did regularly to be able to adjudicate the outcomes that were associated with that. I needed OBGYNs because we had a hormone therapy trial, so we needed to be able to do endometrial biopsies in individuals who bled on therapy to be sure that they hadn't developed endometrial cancer. And of course, we needed oncologists because if we detected early cancer, we also needed to make sure that they actually were followed in the healthcare systems. We needed recruitment and retention. It's not easy. We recruited over 4,000 women just here at Ohio State University alone. So, and we not only wanted to recruit them, we wanted to maintain them for the duration of the study, and we're rather proud that we still have over 89% of the women that are still alive that originally came in the study that continue to be involved now more than 25 years later. And then we have laboratory staff for processing the biorepository, including PAX gene types for RNA, DNA, and other types of things that work together. So why is WHI such a good example of things that are best addressed by a kind of a multidisciplinary approach towards team science? Well, first of all, we had a lot of idea what the problems were, but we didn't really have tight definitions regarding that. So what do we mean by low-fat dietary modification? Is it modification of all fat? Is it modification of very specific types of fat that we should be able to look at this? We brought in multiple stakeholders with a lot of vested interests. So NHLBI, for example, was very interested in the impact of hormone therapy, which at that time was really thought to be, in fact, a significant and major contribution to reducing risk of cardiovascular disease in women as they age, whereas the National Cancer Institute was very concerned about its potential risk for the development of breast cancer and other estrogen-sensitive cancers. So again, bringing together expertise from all of those areas. There's also kind of a disparity of resources, okay? There were smaller institutes, or there were multiple investigators who similarly had questions that would align with this, that could actually leverage the scientific foundation that WHI put forward. And then these were very complex problems, because what we had done in clinical trials prior to that is really put on our blinders. We focused on one specific set of questions, but in fact, we know that any single therapeutic agent has off-target tissue effects. So it doesn't just affect the heart, or it doesn't just affect the breast. In fact, we need to look at that overall balance of risks and benefits. So there's a tremendous amount of uncertainty associated with that complex problems that really required an entire team of scientists and then an entire team of people to actually implement the protocols. And no single individual or no single institution by itself could actually conduct a trial that involved 161,000 people over more than a decade of time. So what reasons did we then have to collaborate? Well, it allowed us to bring in a tremendous amount of expertise and different skills to the table. And as I'll show you, we've continued to bring new skills over the decades to really address kind of more sophisticated issues as time has evolved. It gave us access to multiple increased resources. So by bringing different techniques together, by bringing different institutes, each of who could help to support some of this, it really was an economy of scale. So even though we've spent more than about $800 to $900 million on this study, as you'll see, the impact in terms of women's health has been enormous. It actually allowed for cross-fertilization across disciplines. And I always use as an example of this is the fact that I remember sitting in a room once and hearing the low-fat dietary modification people talking about the primary hypothesis for why this might decrease breast cancer was it actually reduced estradiol levels. Well, I'm a metabolic bone person. Reduced estradiol levels, even in the postmenopausal period, had data that suggested that there'd be an increased risk of fractures. So immediately, their insight made me think about kind of a new problem that might be associated with that in ways that I might need to intervene. And then this became an incredible opportunity for actually training the next generation for investigators. There is a continuum when you think about working on a research team. So for many of you, when you're first starting off, you work in a relatively small team. Your research laboratory may include 1 or 2 research assistants or clinical research coordinators. You may have a biostatistician and that you work with regularly. You may access biomedical informatics, but it's much more focused on a group of scientific problems that you can address individually. As you deal with bigger and more complex problems, you'll actually are likely to move into developing research collaborations, where you may work in what's considered a multidisciplinary approach, where you actually each take a component of the problem and do your primary focus on it, but in fact, they're integrated at the end rather than being integrated. And once in a while, you reach that secret sauce, that interdisciplinary or transdisciplinary team, where each of the research members of that team actually bring their own perspective, but they transform to work in ways that they never thought that you can actually begin to address the problems. And really the process of doing that requires you to have open communication, to work a little bit outside your comfort level, to appreciate the expertise of others, to openly share your data. And although there is a leader often of these teams, it's a shared leadership model, and as different components of the study move forward, that leadership can change. And so in establishing your research team and in establishing this, we clearly had a vision of where we wanted to go. We needed to empower our group in order to be able to actually all feel that we had a say in moving things forward. We had to develop that trust, which comes across time, and that really bases on sharing of credit so that everybody's a winner at the end, and then having communication strategies so we continue to know where the projects are going and where the different pieces work. One can develop that research team from the top down. So WHI was a top down, right? So NIH actually developed and said these are issues. They put out an RFA, and our national research team was really responding as a result of that and developing. There's other ones where you have a question, you need to answer that, you need additional expertise, and that comes from the bottom up. And certainly within WHI, all of the work that I've done over the past decade in genomics and proteomics has all come from the bottom up, where we actually asked the questions, found the experts, and added new people to the WHI community. But remember that there is risk, okay? Because when you become part of a team, you did give up a little bit of your status as being the lead, the most special, the only one that's working in this space. You give up some of the power. You actually have to compromise sometimes or to find common grounds with which to work. And of course, you give up your autonomy. So that in deciding how much you want to move towards that transdisciplinary approach really is where your comfort level is, and in fact, sometimes where your career is and how far along you are. So I'm going to put this all in perspective pretty quickly in terms of Tuckman. So how many of you have seen this Foreman, Storman, Norman performing and then transforming? Have you all seen this model before? So this has been around for a long time, right? 30 plus, 40 years. But in fact, it continues to be true today. So at the very beginning of WHI, if you think about that first investigators meeting we came, we really were forming, right? So we were very polite. We sat around in the room. We all introduced ourselves. We said what our expertise. How many of you have been part of that first meeting, right? When you're trying to kind of feel out each other and show them what you are and what you can be. And it's a very positive. People are excited to be part of this. They can see that bigger vision. And you begin to lay out some of the project goals and some of the individual responsibilities for everybody working together. And in fact, at that point, you really don't have any conflict, okay? You're simply beginning to come together to actually clarify the accountability, and it's really led. And at the beginning, this was led by NHLBI and the program officers that moved forward. They moved into that storming phase. And so the storming phase is where you're actually now getting down into the nitty-gritty of how are we actually going to do this? How are we going to bring everybody together to actually reach that goal? And at times there's real clashes, okay, where you say, well, where are we going to put our greater resources? Is it going to be to recruit the hormone trial earlier, or is it going to be looking at the dietary modification? Because we all have limited resources, no matter how large that number of resources are. And so things kind of fluctuate as you kind of work to figure out how to problem solve together as a team and move things forward. But it's an important time to actually bring those things out in the open and have those communications, because that allows you to move forward to the next, which is norming. And at that point, you reach that level of team cohesion. And so WHI really did that probably mid to the end of the recruitment period. So after that first 3 to 4 years, where in fact the investigators really had formed a team working together. We had multiple subgroups, and so we actually facilitated others to lead. So the nutrition groups really were capable of running and pulling together those things and working together across the 40 clinical centers. We actually had feedback to the PIs and the others, and NHLBI began to actually give to the WHI investigators the power to run these teams rather than this being from a top down. So now we actually developed the leaders within the WHI community and took forward the responsibility for managing that. And then it was a performance, because this is a 10-year, 3 sets of interventional trials and an observational study. And it was a place where we actually were really safe to be able to say what's working well, what's not working well, have that feedback, have these very transparent, open data on how well everybody was performing, and then jump in there and help the centers that were actually having problems in one area or another. So that allowed the task to be done effectively for the betterment of everybody. So it was that development of interdependent relationships between all of these things that really allowed us to become successful. So as many of you know, in 2002, we reported the results of the first hormone trial, which we closed early. In 2005, the second hormone trial was closed. And in late 2005, the dietary modification in calcium plus vitamin D. And so we really worked over that first decade plus in meeting the overall initial objectives of the WHI. But for those of you who work with cohorts, you know that we never like to let cohorts die. So the cohort continued to live. So we needed to think about, well, what really now, what's the next steps for WHI? How do we transform this? Okay, should this team go away, or do we actually think there's great value for moving this forward and continuing to work with these women that were actually dedicated to getting answers for women's health? And so we really began to look at this as a scientific resource where other ancillary studies or things could be done that would address it. And so we began to recruit other scientists from around the country to actually use WHI to collaborate with us and to embed studies on top of this. From 2010 to 2020, because of the trust, we went from 40 individual clinical centers, and we actually collapsed down to 4 regional centers. And we did it in a way that was actually very friendly. We just chose 4 groups and said, okay, you lead it. So I'm the PI of the Midwest Regional Center, and we now are responsible for all the scientific work and activities that go on in the Midwest portion of the United States, and all the scientists, both within and new to WHI, who collaborate within this. And now in these latter phases, we've continued to bring in multiple other individuals from around the world, particularly in the T1 sciences and in fact in basic science. So as we define, for example, new genes that are associated with targets, we actually go back and are doing zebrafish studies and things like that. So collaborating in some ways, that's a long way from that public health perspective of epidemiology where we started, but that's driving science that we can go back and continue to address in WHI and others. What's the impact? The impact has actually been more than any other study that's ever been funded by the NIH. So to date now, there's more than 1,400 publications, 289 funded ancillary studies, and just the hormone trial alone has been estimated to have saved healthcare about $35.2 billion, let alone the calcium, vitamin D, and dietary trials. But I think more importantly, those stakeholders who originally advocated for this study, who've been part of this team from the very beginning, and that's really our participants, are now empowered with better information in order to make decisions. There's no right or wrong, but at least they have the data now to actually choose what's most appropriate for them. So how do we sustain all of this? Well, the first is to clarify. We thoughtfully really laid out our purpose, and we continue to do this every year in terms of understanding what are desired objectives, and then what's the kind of team, who are the types of people we should really reach out to, and suggest that this is a good group to work with. And so initially it was a group collaboration. It's kind of moved into leadership. I'm currently, for example, the National Steering Committee Chair of WHI and have been for the past couple of years. It's about communication, so we continue to have regular monthly conference calls. We continue to have special interest groups. We have an annual face-to-face scientific meeting, which is going to be hosted at The Ohio State University this year, all of which to really share scientific advances, new ideas, to break into groups, and continue to look, are there pragmatic trials that we can put on top of this, or other things that continue to make this be valuable. But I think it does make sure that we close the loop, that we give other opportunities to people to collaborate with us, and that we consider that everybody's contribution is valuable. So it's really walk in someone else's shoes. Don't only think about it from your own perspective, and to care about everybody's success. Because if they're successful, I'm successful, and the WHI is successful. And it was also about building the trust, ownership, and empowerment. And I can't tell you how important that is. If you feel that this is your study, okay, you ask women, why did you do WHI? And what they'll say now, even 25 or 30 years later, and they all wear their necklaces that we sent them, or they wear their pins. And in fact, in virtually every woman's obituary, her family member puts that one of the proudest moments of their lives was to contribute to an understanding. Because they feel like they were, which our tagline was, they were part of the answer. And being part of the answer really allows them to be active contributors. And I think all of us as investigators, literally thousands of people who've collaborated with us now in WHI have been that. And so having that shared sense of destiny together was ultimately important. So I close by my favorite quote, which was Henry Ford. So think of this is more than 100 years ago, and we're continuing to have those same discussions in translational science. That coming together is the beginning, keeping together is progress, but working together is success. Thank you all for coming, and I hope this is a wonderful and valuable day for you.